Okay, it's 2 o'clock now. So we will start. Sorry about the latecomers. Okay, so today's talk is about understanding eye movements, and I'm just going to turn off this so that I don't get distracted by the latecomers. Huh? Okay, so is to understand eye movements in a simple and logistical manner. And for that, we are basically going to use a very simple approach. The basic tools we're going to use is 2x and this arrow. So with just these three tools, or the two tools, the X and this spatula, we should be able to figure out how to sort out eye movements. And at the end of the session, you should feel that eye movements and nystagmus are beautiful, and just in the name of diversity, beautiful in both ways. Okay, so let's start. So this woman has got problems with her vision. Okay, as you can see, I just want to make sure that I'm not muted accidentally. Okay. Okay. So you can see from the reflection of the ambient light that this light here, the ambient light is reflected right spot on in the center, but this is slightly off center, which tells us straight away that there is something wrong with the orientation of the visual axis. So one eye is either abducted or adducted at rest position. So to confirm that, if you move the eyes in the primary positions, which is up, down, left, right, you notice that the abnormality is most obvious when the patient looks to the left. And you can see here clearly the reflection of the light is here. Here the reflection is the light is here. So clearly this eye is not abducting as much as it should. So how would you approach this in the name of what I just said? So basically you draw 2x, okay, 2x like this. And then you'll draw the two arrows. In this particular case, the two arrows that are not working, of the two arrows, the arrow that's not working is this one, correct? So the next diagram should look like this, okay? Then when you connect these arrows to the relevant nerves, you get something like this, correct? So then you realize that the pathology can be in the muscle that is preventing this eye from abducting. It could be in the neuromuscular junction. Therefore, this eye is not able to abduct, or it could be in the nerve. And if it's the nerve, it is the sixth cranial nerve, correct? So that's how you would approach this patient's problem. Now, if it is indeed, if you have thought about this patient carefully and you ruled out muscle, a localized muscle pathology like a restrictive problem. Restrictive problem means the muscles are fibrous. So this muscle is supposed to move to the left, this muscle is supposed to move to the right. So if one muscle is super fibrous, it's not going to allow the other muscle to move, right? So this is what we call restrictive ophthalmopathy. So localized muscle disorders, like for example, in thyroid eye disease can do that, okay? So if we have ruled that out, and then if we have thought about neuromuscular junction and ruled out by looking for signs of fatigability, then the remaining cause is the sixth cranial nerve, correct? So if it's sixth cranial nerve is a, sixth nerve is a cranial nerve, right? So straight away you have to invoke the laws of cranial neuropathy. So the 4+1 rule. So in this particular case, you have to examine the patient carefully. She couldn't abduct the eye to the left, right? So she could have a left sixth nerve palsy. If she does have a left sixth nerve palsy, maybe it's in the left pons. How would you know it's in the left pons? Because she would have other cranial nerves that are coming from the left pons. She would have drowsiness. And if you examine the limbs, she would have signs of pyramidal and cerebellar signs that will point towards a brainstem localization. Okay. Now, if it is not in the brainstem, then it could be one of the cranial nerve clubs. And we've already discussed this before. Sixth nerve is associated with two prominent clubs. One is the orbital apex superior orbital fissure club, or the other one is the cavernous sinus club. In the orbital apex superior orbital fissure club, you have the second nerve, the sixth nerve, the fourth nerve, the fifth nerve, and the third nerve, right? So the second and the fifth nerve joins the oculomotor nerve as well as the fourth and the sixth nerve, okay? In the cavernous sinus, the second nerve is not there, but the fifth nerve is very prominent there. Bigger components of the fifth nerves are there, okay? So therefore, you would examine this patient carefully for the second cranial nerve, which means you look at the pupillary response carefully, you look at the visual acuity carefully, make sure second nerve is not involved. And then in the eye movements, you've done the cross, but you should now subsequently go and do the H and look carefully for evidence of fourth nerve problem or third nerve problem that's associated with it. And finally, you'll examine the patient's facial sensation and corneal reflex to see whether the fifth nerve is associated. And if it is indeed affected, then you would invoke the possibility of this being a cavernous sinus club. Now, the next rule of the cranial nerve tells you that during your cranial nerve examination, you have to think about and rule out actively evidence of meningeal disorders like meningitis or skull-based metastatic disease, right? Skull-based metastatic or some other pathology in the skull base. So you will look for headache, neck stiffness, lymphadenopathy, fever, headache, vomiting, and all the other symptoms that will suggest meningeal and skull-based pathology. And then finally, we know that after you finish your cranial nerve examination, as you go to the limbs, just like you look in the limbs for evidence of brainstem dysfunction, meaning upper motor neuron signs in the limbs, you would also think about ruling out peripheral neuropathy like Guillain-Barré syndrome actively by looking for evidence of areflexia, ataxia, and sensory loss, which would suggest a diagnosis of peripheral neuropathy or one of its the diagnosis of peripheral neuropathy, specifically Guillain-Barré syndrome or one of its variants. So in Guillain-Barré syndrome, there are many variants. One of them is associated prominently with eye movement abnormalities, the so-called Miller-Fisher variant, and that is associated with distal sensory loss, distal areflexia, as well as ataxia in the limbs. Okay, so you need to look out actively for these signs. Then only after you've ruled out all these things, then you may want to consider whether this patient's sixth nerve palsy is due to an isolated sixth nerve palsy from a diabetic patient having an ischemic sixth nerve palsy. Okay, this is the most important cause of an isolated, and indeed, only after you've thought about all these things actively, rule them out, then you can invoke the +1 rule. Okay, if it's truly isolated, then you have to think about this. But even then, you realize that some of the conditions that we talked about, here, reappear here. For example, meningeal causes, raised intracranial pressure, cavernous sinus, because in the early stages, sometimes it's an isolated sixth nerve palsy. But later on, maybe the third nerve, the fourth nerve, and all the other signs will come. So you still need to keep an open mind about the other causes. But if it's truly, truly an isolated sixth nerve palsy and remains isolated sixth nerve palsy, then we are dealing with a diabetic patient with ischemic sixth nerve palsy. Okay. Now, in this particular case, this patient, in addition to the six nerve, in addition to the abduction deficit, had decreased sensation of the left face. She also had decreased corneal reflex. Okay, a second cranial nerve was affected because when we tested a visual acuity was much reduced compared to the other side. So in other words, she has a second cranial nerve, she's got a sixth cranial nerve and a fifth cranial nerve. So this localizes to the orbital apex, and indeed you can see the redness of the eye, and that's because she has got this unusual condition where the carotid artery communicates with the cavernous sinus, and the cavernous sinus blows up, okay, with arterialized blood, and the blood is transmitted forward to the orbital fissure, orbital apex. So she gets a combination of signs from both the orbital apex as well as the cavernous sinus. So she's got sixth nerve, fifth nerve, and second cranial nerve. And with time, she would start to develop other cranial nerves like the fourth and the fifth nerve, unless this problem is addressed. Basically, the carotid artery, which is sitting next to the cavernous sinus, instead of being a discrete structure, it forms a fistula. So the carotid artery now is pumping arterial blood into the cavernous sinus and arterializing it. So that's why these patients develop severe pressures in the cavernous sinus and orbital apex, developing second cranial nerve, sixth cranial nerve, fifth cranial nerve, occasionally fourth cranial nerve, third cranial nerve, and all the other signs associated with it. And then, of course, the congestion and redness of the eye is due to the venous hypertension that occurs when the artery connects with the cavernous sinus. Okay, so this particular patient, final localization because of the combination of cranial nerves was in one of the clubs. In this case, combination of both orbital apex and cavernous sinus. And that the reason we were clued into the diagnosis because she had the associated cranial nerves, which is second, fifth, together with the sixth. And with the redness of the eye, we went on to image her and found that there was a fistula in the carotidocavernous region. Okay, now let's go to the next patient. So if you can see this picture, you can see that there are a lot of things happening, but the most important thing is to remember what you want to draw in terms of the egg diagram. So remember, you need to draw an egg diagram like this. So one second, just make sure that my here miscommunication with my son. Okay, so let's start again. So you remember, you're supposed to just remember to draw the egg diagram and figure out which one is not moving. Okay, so in this particular case, if you look carefully, okay, this eye is not adducting when he looks to the left. When he abducts, when he looks to the other side, both eyes are able to abduct and adduct very well. But when he looks to this side, this eye is not adducting, this eye is abducting very well. So if you were to draw a simple egg diagram, you will realize that in this direction to the left again, just now the patient's problem was in this arrow. Now the problem is in this arrow, correct? Okay, so if you connect this up again, this is the third cranial nerve and this is the sixth cranial nerve. So again, you have to start thinking about what are the possible causes of this redness here. It could be a localized muscle pathology in this muscle that is causing adduction. Just now it's the lateral rectus muscle. Now it's the medial rectus muscle. It could be again a neuromuscular junction problem. It could again be a third cranial nerve problem because we haven't really tested all the other eye movements. So he could easily have a third cranial nerve problem. But in addition, you realize there is a problem in this diagram because the third cranial nerve lives in the midbrain. The sixth cranial nerve lives in the pons. Okay, so the pons is here and the midbrain is here. So this is on on a different floor. If this is a apartment complex and this guy is living on the sixth floor, this guy is living on the third floor. So how is this guy going to communicate with this so that these two movements are simultaneous? These two movements are simultaneous. Obviously, there must be an elevator that will connect the sixth cranial nerve to the third cranial nerve. This elevator is known as the medial longitudinal fasciculus. Basically, it's a myelinated trunk that conducts information from the sixth cranial nerve to the third cranial nerve so that they can both fire together. Because if they don't fire together, if this guy fires on his own and this guy fires his own, this patient is going to get double vision, right? So the medial longitudinal fasciculus ensures that when the patient looks to the left or right, the sixth and the third cranial nerves are coordinated. Now, so you realize that if this is the case, this redness of this arrow could be due to a muscle, neuromuscular junction, nerve, okay? But in addition, it could also be the problem in this elevator, correct? It could be a problem in this elevator. So a problem in this elevator is known as internuclear ophthalmoplegia. Why is it called internuclear ophthalmoplegia? Because it is an ophthalmoplegia that occurs because there's a communication block between the sixth cranial nerve and the third cranial nerve. So you realize that this patient's problem now could be a muscle problem, okay, localized muscle problem, restrictive muscle problem like thyroid disease, could be neuromuscular junction problem, okay, could be it could be a third cranial nerve problem, okay, or it could be a problem in the communication between the sixth and the third cranial nerve. Okay, so these are the various causes that you have to think about. Now, so in this particular case, of course, we went on to examine this patient. Okay, we examined his all eye movements and the pupils also we checked. So there was nothing else that was wrong with the third cranial nerve. So we don't think that this adduction deficit is due to a third cranial nerve problem. We also looked carefully for evidence of neuromuscular junction pathology like fatigable ptosis, and there was nothing to suggest neuromuscular junction problem. And then we examined this patient's orbit carefully, and there was nothing to suggest a problem of restriction like thyroid eye disease. Thyroid disease is a classic cause of restriction of the eye movement or restrictive ophthalmopathy. So there was nothing to suggest that. So then we started considering whether this patient's problem could be in the medial longitudinal fasciculus, okay, suggestive of internuclear ophthalmoplegia. And that's when we realized that there was one other physical finding that was very interesting. And that is the right eye that's abducting very well, doesn't just abduct, but it also seems to be having a bit of eye movement, which is basically a spontaneous eye movement with a fast phase and a slow phase, a fast phase and a slow phase, a fast phase and a slow phase, right? So that is a nystagmus, but the nystagmus is occurring only on one eye. Okay, this eye, this so-called abducting nystagmus, okay, tells you that the pathology is likely to be in the medial longitudinal fasciculus. Why do we say that? Because what happens is, in this particular patient, this eye is supposed to look to the left, correct? It's supposed to look to the left. Now, at this point, when you're supposed to look to the left, this eye is able to abduct, no problem, because the signal is getting through. But this signal is not getting through, right? It's getting blocked here. So what does the brain do? It sends more signals down. The more signals that are sent down is able to go to this eye without any problem, but still gets blocked here. Okay. But then what does the brain do? It sends even more signals. Now it sends 3 times the amount of signals. The 3 times the amount of signal is still sent to this eye, but the block is still there. So therefore, even though it's 3 times the signal doesn't get through. Okay. So in other words, the 3 times signal doesn't get through. But this poor eye here now is getting 3 times the amount of signal that it normally needs. So what's going to happen to the eye? Obviously, it's going to overshoot the target. Okay. So this overshooting is the fast phase that you're seeing. Okay. Overshooting and then it comes back. Overshooting and comes back because the signal to this eye is 3 or 4 times the signal that was meant to be given to it. Because of this block, the brain keeps sending in more and more signals. So the overstimulation of this eye results in this eye overshooting. And when the overshoot stops, it comes back. It overshoots and then it comes back. It overshoots and then it comes back. It overshoots and it comes back. And then when you look at it from far, it's a classic nystagmus because there's a fast phase and then a slow phase. Fast phase and then a slow phase. Fast phase and then a slow phase. Okay. So that is the classic abducting nystagmus that you see in internuclear ophthalmoplegia. So with the exclusion of localized muscle disease, with the exclusion of fatigability, with the exclusion of other eye movement abnormalities associated with the third nerve, and with the presence of this abducting nystagmus in the other eye, we concluded that this patient's problem is a lesion in the medial longitudinal fasciculus, and the pathology is known as internuclear ophthalmoplegia. Okay, now, so that's what he has. Okay, now let's move on. So this is another patient that looks very complicated, but again, remember, I want you to just like we do for our weakness formulas and various other formulas, we have to go step by step. We have to go step by step. So we break down one step and then we go to the next step. We break down one step and then we go to the next step. Okay. So in this particular case, the patient was looking to the left and then looking to the right. So all you need to do is decide on the egg diagram which arrow is not working. Okay. So now let's play it. Don't worry about all the vertical eye movements. Just we're only considering horizontal eye movements now. So, okay. So if I were to just make it simple for you and break it down in 2 steps, okay? Now she's going to look to the left, okay? Okay, which eye is not moving? This eye is not moving. So your arrow should look like this, okay? Now, if I let the video play so that she can look to the other side, let's see what is not moving. Then you realize, oh, this is not moving, okay? Okay, if you don't believe me, you can play it again. So when you look to the left, this eye is not moving. So we drew that arrow as red. But when you look to the right, this arrow is not moving. So in other words, for the looking to the right, this arrow should be red. Now, if you put these two diagrams together, you get a composite diagram like this, 2 red arrows like this. Now we sit down and think about it systematically. Could this be a muscle problem? Yes. But then how can you think about a muscle disorder that is so selective that is only affecting 2 of the adducting muscles? Okay. So thyroid eye disease can cause restriction of various muscles, but for it to affect just 2 muscles, and as you can see, there's no other signs of thyroid eye disease like hyperthyroidism signs like little retraction, little lag, and all these things. So I think we can safely conclude that it's not a muscle problem, right? It could be a neuromuscular junction problem, definitely. Okay, it could be a neuromuscular junction problem. This lady could easily have myasthenia gravis, and if we go on and examine other signs, maybe she will have fatigability. Okay, now she could have a bilateral third nerve palsy, possible, right? Bilateral third nerve palsy, but you would expect other eye movements to be abnormal at the same time. But then you realize that in addition to these 3 entities, the 2 elevators are actually next to each other in the central area of the brainstem, right? From the pons up to the midbrain, the 2 elevators are traveling next to each other, okay? They are forming 2 parallel tracks. So you can't, it's not inconceivable that there is a small lesion that straddles the midbrain and affects both medial longitudinal fasciculus. A small lesion that is affecting both these tracts in the central part of the brainstem. Okay, you can think of various pathologies, whether it's a brainstem tumor, this a demyelinating lesion in the brainstem, or whether it's a basilar artery. As you know, basilar artery, we discussed a patient with basilar artery stroke last week. A basilar artery is right in the center, so it innervates both parts of the brainstem. So basilar artery disease could easily cause this. A demyelinating plaque that's sitting here exactly where this lightning bolt is could demyelinate both these tracts and cause the same kind of pathology. So this lady could easily have bilateral medial longitudinal fasciculus lesion. So the differential diagnosis are, number one, a low probability of this being a restrictive muscle problem. Number two, a real possibility of this being myasthenia gravis. Number three, a moderate possibility of this being bilateral third nerve palsy, okay, and a real possibility of this being bilateral medial longitudinal fasciculus. So what could we do to differentiate between these four entities? Okay, in the next video, you will see one particular maneuver that's being conducted that will help you differentiate between the four entities. Okay, I'm just going to let the video run. She looks to the left, we saw the deficit. She looks to the right, we saw the deficit. And then now I'm going to ask her to converge on my pen. Then suddenly the muscles that were weak seems to be moving perfectly well. Okay, now we go back to this diagram again. Okay, now if this was a muscle disorder, could it be overcome by convergence? No, because the muscle, if it's restricted, it will be restricted no matter what you do with the eye movement. So the fact that it's overcome by convergence means it cannot be a muscle problem. Can it be a myasthenia? Cannot be myasthenia again, because if it's myasthenia, again, because the neuromuscular junction is faulty, the eye movement, the adduction will be weak, whether you're asking the patient to look left, look right, or converge. Whatever the stimulus, the same problem will exist. Likewise, if it's a bilateral third nerve palsy, whether the patient is asking to look to the left or look to the right or converge, the same movements will be abnormal. But in medial longitudinal fasciculus lesion, possibly if you think a little bit about what you remember from anatomy days, you know that the third nerve is in the midbrain, okay? The sixth nerve is in the pons, right? And the medial longitudinal fasciculus is traveling all the way from up here, all the way to the third nerve. Now, if there's a lesion in this tract here, okay, now it's going to affect this ability to look left and look right. But what about convergence? Now, if you realize convergence is not the same thing as looking left and looking to the right, you may have realized, and now if you look at my video, look straight at my face, I'm able to look to the left, I'm able to look to the right, I'm able to look to the left and right in response to an external stimulus, or I can voluntarily also move to the left and right on my own. Okay, that means I can even move the left and right with my eyes closed or in darkness. Even with my eyes closed, I can move my eye to the left, I can move my eye to the right. Okay, no problem. But convergence, on the other hand, is a very different eye movement. Okay, it looks the same, but it's not the same. Okay, it firstly requires a stimulus. You cannot converge your eyes without a stimulus. You can try now. You try to converge, no matter how hard you try, you cannot bring your two eyes together. But the moment you fixate on an object, you can converge. Right? I'm converging now, right? I'm converging. I'm only able to converge because I've got an object, which means when I close my eyes, I cannot converge. When in the darkness, I cannot converge. So you realize that convergence is a completely different eye movement from horizontal saccades that is controlled through the medial longitudinal fasciculus. And indeed, convergent fibers have got a slightly different pathway and they go directly to the third nerve. They go directly to the third nerve. So a lesion in the medial longitudinal fasciculus may not affect the convergent fibers because the medial longitudinal fasciculus lesion is here. The convergent fibers are going straight to the third nerve in the midbrain. So in this particular case, this lady has got a tumor in the pons that's demyelinating the medial longitudinal fasciculus in the pons. So therefore, when she looks left and looks right, she's got bilateral INO. But in the midbrain, her third nerve nucleus is perfect. So she's able to, the convergent fibers are directly going to the third nerve nucleus in the midbrain, and she's able to converge beautifully. And with that, we know for sure this patient can only have bilateral MLF or bilateral internuclear ophthalmoplegia as the cause of a problem, because muscle pathology, neuromuscular junction pathology, bilateral third nerve pathology cannot possibly explain this discordance between lateral eye movements and convergence. Okay, now I'm going to pause here and allow questions. If not, we'll go on to the next question, next case.
Hi, Prof.
Yes.
Hello, can you hear me?
Yes. I can hear you well. Question?
Oh, yes. So I was wondering, sorry, what exactly do you mean by the restriction in the hyperthyroidism? Like, what exactly does that mean?
So in hyperthyroidism, the muscles are restricted because they are fibrosed. So therefore, if you go and read your chapter on thyroid eye disease and what happens to the muscle, there will be a lot of explanation about what is the pathology and thyroid eye disease. It's beyond the scope of this lecture, but we must remember that it's thyroid eye disease is an important cause of ophthalmoplegia, but the ophthalmoplegia is not due to a nerve problem. It's not due to the neuromuscular junction problem. It is the muscle itself that's fibrous, and once it's fibrous, it's not able to function well. Okay, so the term we use is
Okay.
restrictive ophthalmopathy, as opposed to muscle,
Oh,
as
that,
opposed to
yeah.
nerve problem or neuromuscular junction problem, where we use the word, where we don't use it, but we imply the term paralytic ophthalmopathy. In thyroid eye disease, the muscle is restricted, therefore it cannot move freely. Okay, so again, please do read about it. It's an important internal medicine topic that you may need to know. Okay.
Sure. Thank you so much. Yeah.
Hi, Prof. I've got a question. So you mentioned that like for INO you get the classical nystagmus. So if it's bilateral INO, will you get like a bidirectional nystagmus?
Yes, indeed. If you look at this lady carefully, you may perceive a little bit of this there. Can you see that? Can you see that? So she does have it. It's a little bit complicated because there seems to be a vertical component to it, but majority of the nystagmus is beating towards this direction. So indeed, it's a good question. And let me just play it again to show you that when she looks to the left, this eye is abducting a bit, abducting nystagmus here, and this eye is having abducting nystagmus. So the normal contralateral eye that is fully abducting gets too much of stimulus, so it overshoots the target and it manifests as a abducting nystagmus. Okay. 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 So while the rest of you are thinking about questions, the next one is actually a quiz. Or no, actually not a quiz yet. There's one more thing, then we'll give you a quiz. Okay, so this lady is unable to look to the left.
Look to the right.
No problem.
Now look as far as you can to the left.
Okay, now she's trying to look to the left, as Dr. Z is trying to say.
Right. And as far as you can to the left.
Nothing is moving. So again, you may think of various diagnoses, but again, as I've always been emphasizing from the very beginning, whether it's weakness, blurring of vision, cranial neuropathy, always use a formula, right? So in this case, use the X, even though you think that you know the answer, do the workings properly. So in this case, if you draw the X, 2 arrows to the left, 2 arrows to the right, no problem, right? She can look to the right, no problem at all. When she looks to the left, what happens? Both arrows are red, correct? Now, so then you just connect up the lines. So this arrow, lateral rectus muscle, connect to the 6th nerve, all the way to the 6th nucleus in the pons. This one is connect to the 3rd nerve, all the way to the 3rd nucleus in the midbrain. And then, of course, you have the elevator that connects the 2 of them. Okay. Now, even if you have absolutely no knowledge, in fact, if you have a non-medical person in your household, you can show this picture, ask them to do like a puzzle. Where can you put a cross? You know, like pinning the tail on the donkey kind of game. Where can you put a cross in this diagram to allow both these arrows to become red? Where can you put a cross? Okay, if you put a cross in here, this will be red, but this will not be red. Okay, in the first patient, we put a cross here. This was red, this was black. Okay, but how can we make both of them red with just one cross? Obviously, many of you would now understand that you'll have to put a cross on the 6th nucleus itself. Now, at this point, you realize that the 6th nucleus, remember last week we discussed the problem with the 3rd nerve. The 3rd nerve, when it becomes the nucleus, in the nucleus itself, the structure of the nucleus is more complicated than the nerve itself. So likewise, the 6th nucleus that's located in the pons, not only does it have cell bodies that control the 6th nerve, but it's actually controlling the whole of gaze to the left. So therefore, a synonymous name for the 6th nucleus is the lateral gaze center. Okay, synonymous names. Okay, so 6th nerve, like the first patient, remember the very first patient with the carotidocavernous fistula, 6th nerve lesion. Okay, she only had problem in the 6th nerve, so only this eye wasn't moving. But if the 6th nucleus is affected, not only is this eye not going to move, the whole of gaze is affected. So therefore, when it's a 6th nucleus problem, we call it the lateral gaze center problem. Okay, so you would put an arrow here, and that will elegantly explain what this patient cannot do.
Camera. Look to the right. as far as you can to the left. Right, and as far as you can to the left.
So therefore, she has a lesion in the left pons, okay, affecting the left 6 nucleus. Now, many of you be wondering then, how come we are only talking about the brainstem? There must be control of the eye movements from other centers, right? Because brainstem is a reflex center. There must be higher cortical control. For example, our ability to move our eyes is just like any other action, right? We have voluntary action. I want to move my right hand. I want to move my left hand. Okay. A lot of the reflex of the right hand and the left hand is in the spinal cord and the cervical segment, but the control of voluntary volitional movement comes from the cortex, right? From the frontal lobe specifically. So likewise, okay, how do we voluntarily control eye movements? We must have control coming from the frontal lobe, which is the area where you decide what you want to do with life. Okay, it's where your volition is. In other words, where your soul is, S-O-U-L and not S-O-L-E. S-O-U-L is cited in the frontal lobe. Okay, so whether you want to dress today like this, or you want to drive this car, you want to marry this person, all this is decided by the frontal lobe. Okay, that's where you initiate voluntary action. So this lady wants to move to the left and right. Obviously, the stimulus must come from the frontal lobe. Now, so far, everything I've given you, most of the knowledge is very basic. In fact, you can work it out. Nothing is memorized, right? I don't think I've given you anything that requires memory work. But this is the first thing that I need you to memorize. And the first bit of information that I need you to memorize, because we don't really know why this is happening, that's why we need you to memorize, is the frontal eye fields are crossed. Okay, crossed. So why the frontal eye fields are crossed, nobody knows, but the frontal eye fields are crossed. So in other words, if you want to look to the left, it is the right frontal eye field that sends a signal to the 6 nucleus to move the eye to the other side. Okay, it is the right frontal eye field. So similarly, if I want to look to the left, it is the right front. Sorry, if I want to look to the right, the left frontal eye field will send a signal to my right 6 nucleus to initiate the movement. 6 nucleus, remember, is the gaze center, right? So in other words, this frontal eye field is initiating impulse to this gaze center to initiate this movement. So now you realize that this lady's inability to move to the left, okay, because of the 2 arrows that are red, could be a lesion here, okay, to make this arrows red. It can be a lesion here. But you realize that with this frontal eye field being involved, okay, the lesion could also be here. These will look the same as far as the eyes are concerned, correct? So right frontal eye field will cause inability to look to the left. Left pontine lesion affecting the left 6 nucleus will also cause inability to look to the left. So this lady's pathology could be either in the right frontal eye field where my arrow is, or in the left pons. 2 things will look exactly the same in the picture. And because you only see the 2 eyes here, okay? You don't see anything else in about her. But so how do we differentiate between the 2? Well, it's quite easy actually. The moment, if let's say this is the pathology is here, okay, as opposed to here. Now, as you walk into the ward, okay, this patient with the right frontal eye fields would have pathology in the limbs also, right? Because the frontal eye fields are in the frontal lobe. Frontal lobe doesn't only have eye movements, right? It also has your limb movements. So which side is going to be paralyzed? The left side is going to be paralyzed. So as you walk into the ward, as you see this patient from far away, you'll see that this lady has paralysis of the left side. But as opposed to this patient, okay, when she has a lesion in the left pons, where would a limb paralysis be? Right side, correct? So both instances, the eye movement abnormality, this one and this one, the eye movement abnormalities are the same, but the limb weakness is different. And it's so different that even from a mile away, you'll be able to diagnose it. In this lady, the patient cannot look to the left and her left side is weak. In this patient, she cannot look to the left, but her right side is weak. So straight away, you will be able to differentiate a frontal eye field lesion from a 6 nucleus lesion from far, far away. But of course, we don't do clinical medicine from far away, right? We come to the bedside. At the bedside, you'll see additional findings. For example, this patient, okay, what kind of appearance will she have on her face? Now, in this case, you cannot see a face, right? You can't see a facial appearance. But let's say I open up this screen and allow you to see the face. when you come to the bedside. Okay. If there's a lesion in the right frontal eye field, what kind of facial palsy will she have on the left side? She will have a upper motor neuron facial palsy on this side. Correct? Upper motor neuron facial palsy on the left side. Now, on the other hand, if she has a lesion on this side, if she has a lesion on the left, 6 nucleus. 6 nucleus is linked to the 7th nucleus. So what kind of facial palsy will she get in this particular instance? She will get a left lower motor neuron facial palsy. Now you have 2 tools to differentiate between frontal eye fields and frontal eye fields and 6 nucleus lesion. Frontal eye fields or 6 nucleus lesion. Frontal eye field lesion on the right side will cause left hemiplegia and left upper motor neuron facial palsy. A lesion in the left 6 lateral gaze center will cause right hemiplegia and left lower motor neuron facial palsy. So straight away, you'll be able to differentiate the lesion here and here, not from the eyes, but for looking for other associated signs, because eye movement abnormality will look the same. Correct? The eye movement abnormality will look the same. Okay. So in other words, this lady's lesion could be in the right frontal eye field, which means I will have to open up the screen and look for left facial, upper motor neuron facial weakness and left upper limb and lower limb hemiplegia. If she had a lesion in the left pons, when I open up this screen, I will see that she has got left lower motor neuron facial palsy and right upper limb and lower limb hemiplegia. So straight away, I'll be able to tell you the 2 different causes of this lady's left gaze palsy. One is supranuclear, one is nuclear. Okay. Now, you would have seen patients like this in your ward. Now, many of you would have seen patients with frontal lobe infarction, right? Middle cerebral artery infarction. And you realize that in the wards, people always talk about the eyes deviating towards the side of the stroke. You're not surprised, right? If there's a lesion here, the eyes cannot move to this side. So when given a chance, the eyes will drift towards the side of the stroke. So many times in your right MCA stroke patients, if you lift up the eyelids, in fact, when you go back to the wards later on, find an MCA patient. This right MCA stroke, you lift up the eyelids, the eyes will be at a rest position, will not be at rest, you'll be pointing towards the right hemisphere. If the patient has got a left hemispheric stroke, the eyes will not be able to look to this side. So at a rest position, the eyes would have quietly drifted to the same side of the stroke. So in other words, the way to remember is the cortex is the seat of your soul, remember? So it doesn't lie. It is morally very upright. Okay, it will tell the truth. So when there's a stroke, the eyes are pointing towards the side of the stroke. Always pointing towards the side of the stroke. So that's how you can remember it. But if you don't remember it, if you just draw this egg diagram, you'll straight away know how to differentiate the 2 causes of this lady's left gaze palsy. I'm going to stop here if there are any questions. Okay, if there are no questions,
sorry. So for gaze deviation stroke, you will look towards the lesion. But for seizures, you will look away to the lesion. Could this also explain?
Yes, absolutely. Good point. So if this lesion is, all this we are talking about is the yin part of the yin and yang phenomenon, right? So in this case, these are all lesions that are paralytic. So there is absence of stimulus. So therefore cannot look to the right. But if this is not a thunderbolt, but an electrical discharge here, then this frontal eye field is going to send barrages and barrages of signal to the 6th nucleus and going to push this eye continuously to the opposite direction. So that's why in your textbooks, you often talk about an excitatory lesion pushing the eyes to the opposite side, excitatory cortical lesion like an epileptic focus pointing to the opposite side, while a lytic lesion, okay, a hyperexcitable or inexcitable lesion like a stroke causing the eyes to be deviated to the same side. Good point. Thanks for the reminder. Okay, now, if there are no other questions, then as I said, there were, some of you may have heard me saying there are 3 ways of diagnosing this lady's problem. One is using the side of hemiplegia. The other one is to decide on the type of upper motor neuron or lower motor neuron facial weakness. There's a third step. And the third step requires you to touch the patient. Remember, the first one, hemiplegia, from a mile away, you know the diagnosis. As you come closer, you see the facial weakness, deciding whether it's lower upper motor neuron, you will confirm your diagnosis, or rather you will further corroborate your diagnosis. But to confirm your diagnosis, you need to touch the patient and do what Dr. Z is going to do in this next picture.
Right at the camera, please. Right at the camera.
And he's doing a
So with the VOR, there's no real change.
VOR. Okay,
the
so
camera.
VOR, there's no change. What is VOR? Vestibular ocular reflex. Okay, that's the technical term. A more commonly used term is the Doll's response. Doll's response or vestibular ocular reflex. So Dr. Z is saying with the vestibular ocular reflex, there was no change at all. So that means you're saying that the vestibular ocular reflex can be used to differentiate between this and this. So therefore, if the vestibular ocular reflex can be used to differentiate between this and this, then there's something missing in this diagram. What is missing? The vestibular component. What is the vestibular component? It's the 8th cranial nerve. So that means my diagram is incomplete. I have not included the 8th cranial nerve.
Right.
So we have to bring in the 8th cranial nerve to this diagram. So how can we bring the 8th cranial nerve to this diagram? How can we bring the 8th cranial nerve to this diagram? Okay. So many of you will know this by heart because you've learned anatomy. But remember, I said there are only two things in this whole lecture that I want you to memorize. One I've already used up. I've used up one trump card, which is that the frontal eye fields are crossed. Okay, you need to memorize this bit. Otherwise, you will not be able to sort it out. The 8th cranial nerve, how it's connected, you don't need to memorize. You can just work it out. Because if you now just look at me now, okay, basically I'm moving my head to my left. Okay. Now, this was a fast eye movement, okay? Of course, it could be voluntary, but it's a fast eye movement. So it's a reflex. Now, reflexly, what did my eye do? My right eye abducted and my left eye adducted so that I can continue to look at the green dot, which is the camera. Okay, now I decided to turn the other direction. I'm still looking at the camera. Now, of course, I can do it voluntarily, but this head movement, and throughout the lecture, you notice my head was moving, right? Up, down, left, right. So if I were to voluntarily think about moving my eyes, then I can't be concentrating on the lecture, right? Because my frontal lobe will be thinking about, oh, look to the left, look to the right, look to the left. So what the brain has done is, okay, why don't we relegate foveation when the person is otherwise active? Why don't we relegate foveation to a reflex? Okay, so that the frontal fields can be relaxed to do other things like give the lecture, talk to you, right? Because otherwise I won't be able to concentrate on what I'm going to say to you because all my frontal lobe is thinking about moving the eye. So what is this reflex? That is the vestibular ocular reflex. Okay, so how is it connected? Now you see, if I move my head to the left, okay, I move my head to the left, right? My right eye abducted, my left eye adducted, right? Correct. Now when I move my eye to the right, my left eye abducted, my left eye adducted. Now, semblance of what I'm just describing is already in this diagram. Semblance of what I'm just describing is already in the diagram. So as you know, in science, the nature always finds the easiest pathways, right? If the system is already there, why don't we build on that? So we already have a way of abducting one eye and adducting the other eye. And the control center is in the 6th nucleus. Okay, the control center is in the 6th nucleus. So when I move my head to the left, my right eye is abducting, my left eye is adducting. So which means which nucleus must be active? My right eye is abducting, my left eye is adducting. All I need to do is keep my right 6th nucleus active. Okay, and this movement is fine. When I move my head to the right, my left eye is abducting, my right eye is adducting. So all I need to do is keep my left 6th nucleus active then. So now we have sorted out the efferent part of this pathway. Now we have to think about where is the efferent stimulus coming from, the stimulus to initiate this movement. So now if you look at this, when I move my head to the left and I move my head to the right, now within my ear, there are semicircular canals. Okay, you remember from your anatomy days, there are 3 semicircular canals. One is superior, one is horizontal, and one is posterior. Okay, so the shape is horizontal, posterior, and superior. And these three are positioned in the behind this mastoid bone. Just behind this mastoid bone, they are shaped and like this, and they are angled in this plane. So if you look at my head now, my left eye, from my right side, my right ear, this is the superior semicircular canal. This is the horizontal semicircular canal. This is the posterior semicircular canal. Then if I turn my head to the other side, in my mastoid bone here, there's another 3 semicircular canals. One is pointing up, one is pointing back, one is pointing sideways. Superior, posterior, horizontal. So I have 3 semicircular canals on the right, 3 semicircular canals on the left. So when I turn my head to the left, what is inside the semicircular canal? There's fluid. When you take a glass of water and you stir it, what happens? The fluid will move regardless of the receptacle, right? So in this case, the semicircular canals, when they're moving, the fluid is going to move within the semicircular canals because of inertia. And within the semicircular fluid, what is you have? You have hair cells. Okay, the hair cells are going to pick up this movement of fluid. Okay, that's how the semicircular canals transducts the movement of the head and sends a signal to the brain. So how does this signal work? Okay, for example, if I move my head to the left, the semicircular canal here, the fluid is moving, and there's fluid moving here also. But if you think about it this way, if you just think about it very simplistically, or rather very intuitively, if you move my head to the left, okay, where do you think the turbulence will be maximum? When I turn my head to the left, the fluid is moving in both semicircular canals, both horizontal semicircular canals on the right and the left. But here it has to move and hit against the wall. Okay, it's like waves crashing on the beach, right? It's going to hit against the wall and stop. Okay, while here this is moving away from the semicircular canal. So therefore, between the two, if you think about it, if I move my head to the left, which one do you think intuitively has got the greater signal? The left, where the direction of movement is, or the other side? Okay, if you think intuitively, you realize that when just like waves crashing on the beach, when you move to the left and stop here, the turbulence will be greater here compared to here. Okay, the turbulence will be greater here compared to here. When I turn my head to the other side, the turbulence here will be greater than here. So that is the afferent signal. So now let's think carefully now. When I turn my head to the left, we have already decided my right eye is AB ducting, my left eye is AD ducting. Which nucleus is active? Right 6 nucleus. Okay. Now, when I turn my head to the left, where is the greater turbulence? Left ear. So what you need to do is connect the left ear, the left 8th nerve to the right 6 nucleus, and perhaps you should be able to effect the vestibulo-ocular reflex. Now you try it the other way. I turn my head to the other direction. The turbulence is greater here. My left eye is AB ducting, my right eye is AD ducting. That means my left 6 nucleus is active, but the turbulence was greater in my right 8th nerve. So connect my right 8th nerve to the left 6 nucleus, and we have effected the vestibulo-ocular reflex. So essentially, without learning to memorize, this vestibular dance would tell you that you need to connect the contralateral 8th nucleus to the ipsilateral 6th nerve to form the vestibulo-ocular reflex. Okay, so now you realize that to differentiate between a frontal eye field lesion and a 6 nucleus lesion for gaze palsy, you have one additional tool. You have one additional
Right at the
tool.
camera, please.
He's moving the head to the left and
Right at
right
the
and
camera.
see whether the vestibulo-ocular reflex. This is
So with the
not the
VOR there.
patient moving. No, this
Right
is
at the
the
camera,
doctor moving the
please.
head.
Right at the camera. So with the VOR, there's no real change.
So in other words, if I go back to this diagram, maybe I use this diagram. If the lesion was here, if the VOR is here and the lesion is here, when I do the vestibulo-ocular reflex for frontal eye field lesion, do you think the eye movement abnormality will be corrected? Yes, because the lesion is in the brain, is in the frontal eye field, is in the frontal lobe, sorry, not the brain, in the frontal lobe. Okay, while the vestibulo-ocular reflex is in the pons. So a lesion here will not affect the vestibulo-ocular reflex, and you will be able to move the head and overcome the deficit. While if the person's lesion is here, okay, then the vestibulo-ocular reflex is here. So therefore, this abnormality will not be overcome by the vestibulo-ocular or Dahl's response or Dahl's reflex. So that is the way we differentiate between the two. And now this is not a new concept. If you have a lesion in the cervical cord, your lower limb reflexes are present. In fact, they're hyperreflexive, correct? Because the lesion is above the side of pathology. But if the lesion is, let's say, in L3, L4, then your knee reflex will be gone. So if there's a lesion in the pons, your local vestibular-ocular reflex is gone. If the lesion is higher up in the frontal eye fields, then the local reflex is actually quite normal. So that's how we can differentiate between a cortical lesion in this case and a brainstem lesion for this lady's left.
Right at the camera, please. Right at the camera.
So the absence
So with
of
the VOR, there's no real change.
there's no change in
Okay,
the eye
with
movement.
camera.
It's still difficulty looking to the left. So we concluded
Right.
that this patient's pathology must be in the 6th nucleus. So this lady has got a pontine cause for it. So in other words, you have 3 steps. As you walk into the ward, look for the site of hemiplegia. That will tell you whether this patient's left gaze palsy is it due to a right frontal eye field or left pontine lesion. Okay. As you come close to the bed and you can see the patient's face, appreciate whether she has got lower motor neuron or upper motor neuron facial weakness. If she has lower motor neuron facial palsy on this side, then we know it must be a 6 nucleus lesion on the same on that same side of the pons. Okay, but if she's got an upper motor neuron facial palsy on this side, then we know it's a contralateral frontal eye field lesion. Okay, then the third tool is for you to put your hand on the patient's head and turn the patient's head passively and see whether the deficit is overcome. If the deficit is overcome, then obviously it must be a frontal eye field lesion. If the deficit cannot be overcome, then we are dealing with a pontine lesion. So again, now when you go back to your wards and you see your middle cerebral artery infarction patients, you lift up the eyelids, the eyes are pointing. Let's say the patient has got a right MCA infarct, the eyes are pointing towards the right. So if you were to put your hand on the head and then you just rotate the patient's head left and right, you realize that now when you move the head to this side, okay, the eyes will, even though voluntarily is not moving there, but when you do it this way, you are able to bring the eye to the opposite direction, because by stimulating the right vestibular system, you are activating the left vestibular nucleus and causing the patient to abduct the left eye and adduct the right eye. So this deficit that was present, voluntary movement not there, but involuntary movement is there, will tell you that indeed this patient is looking at her own right MCA infarct and above the side of the local reflexes in the pons, and therefore that's why he's able to overcome with the reflexes. Okay, I'm going to pause here for questions. Okay, if there are no questions, then I'm going to go on to a quiz. For this quiz, I will give you 3 minutes, each one of you to do it alone. And for that is this picture, not a video for you to look at. And again, many of you will come up with spontaneous answers, which again, just like your maths teachers, I'll get very irritated when you give spontaneous answers because it's not foundational, it is memory based. You come up with an answer that maybe guesswork. Okay, we prefer you to do the workings. Okay, just like maths, if you do your workings and you show me your steps carefully, then I know you have understood the concepts clearly, and therefore you will be able to get it right, not only now, but subsequently. Your system is always there for you to get it right all the time, not something memory based that's just pattern recognition, which is very superficial and not foundational knowledge. So don't jump to the gun by just looking at the woman's face and come up with a spot diagnosis. Work foundationally. How do you do that? Well, basically use the egg formula. The first diagram, she's looking at the red pin. Okay, draw the eggs and figure out which one should be. She's looking to the left, right? Sorry, looking to the right, right? So the arrow to the right and arrow to the right. All the others should be black, but these 2 arrows should be red. Okay. Similarly, you look at the bottom picture. Now she's looking to the left. And then you decide which eye is not moving and you draw the red arrow. Then you go back to the first diagram, connect up the nerves and the nuclei and the medial long fasciculus, everything. Then come back to the bottom, connect it up. And then you try to superimpose and see what you get. Okay, I'm going to give you 3 minutes to work each one of you to draw on a piece of paper on your own. And then in about, now it's about 2.5 minutes, I will be able to give you the answer. This is to give you confidence that you can work out what looks like a complex problem, and also to stop people. Some of you may have jumped to the gun and make a spot diagnosis, which is good if you are doing neurology now, but later on, when you're not doing neurology, you forget all the spot diagnosis. Okay, another more minute. Okay, so as I said before, you will break it down into steps, right? So the first diagram, she's looking to the right. Then if you draw the arrows, obviously both arrows will be red. Okay, for both arrows to be red, the lesion can only be in the 6 nucleus. Okay, of course it can be in the frontal eye field also, but we'll keep it simple right here. Of course it can be in the frontal eye field. For this purpose of this diagram, I'm just going to keep it here first. Okay, draw the first part. Okay, then we go back to this diagram again. Now she's looking to the left. Now when she's looking to the left, okay, this eye is not moving, this eye is moving very well. Okay, so you will draw, this is red, this is black. So for this to be red and this to be black, the lesion can be a number of things. Okay, but one of them is medial longitudinal fasciculus. Okay, so if you think about this lesion, it's in the left side of the pons. This lesion is in the left side of the pons. Sorry, right side of the pons. This lesion is also in the right side of the pons. So if you were to superimpose, okay, you realize that this is probably the most parsimonious explanation, because a small lesion in the medial longitudinal fasciculus, a small lesion in the medial longitudinal fasciculus that extends slightly more laterally and touches the 6 nucleus, okay, can actually easily explain all these 3 arrows to be red. Okay, of course, like I said before, individually there are other explanations. Okay, but this is the most parsimonious explanation, because you put a dot here, you put a dot here, these two put together is the most elegant explanation. So a small lesion in the medial longitudinal fasciculus on the right side that extends and involves the 6 nucleus on the right side. Both are on the same side of the brain stem, same part of the brain stem, both are in the pons. Both have similar vascular supply. So anatomically, pathophysiologically, it's very feasible to have a small lesion here. You don't have to think about one lesion here, another lesion here. Remember, in Occam's razor, you need to find one lesion to explain everything. A small lesion here can explain 3 out of the 4 eye movements of normal. Okay, so this is what this lady's pathology is. Now, this, because it is 3 out of 4 eye movements affected, this is known eponymously, or rather syndromically, it's known as the 1.5 eye syndrome. Many of you look at the face like this and make spot diagnosis, which is not foundational. I'd rather not you make the diagnosis. And as I said, it's not important diagnosis. What is important is using this egg diagram to work it out, so that use this kind of formula can then be also used for other more complex eye movement abnormalities. Okay, but this is one complex eye movement abnormality that you were able to work out without pattern recognition, but by using the egg formula, systematically drawing one of the drawing the diagram and drawing where the lesion could be. Okay, okay. Any questions? Okay, if there are no questions, I'm going to go do a quick summary so that we don't lose you, because some of you may find the pace a little bit fast. Okay, so basically we start off with testing the eye movements, right, in the cardinal planes. So using the egg diagram to decide which arrow is not working. And then you connect up the arrow to the relevant nerves and the nuclei. But you must remember, it's not just the nerve that could be abnormal, it could be a muscle problem. And if it's individual muscles, you must always think about a localized muscle pathology, like fibrosis of the muscle that occurs in, for example, thyroid eye disease, or it could be a localized neuromuscular junction problem affecting that particular muscle. After you have ruled that out, then you have to think about the nerve. And because we are dealing with nerve, whether it's the sixth cranial nerve or the third cranial nerve, you use the 4 rules of the cranial nerve and you work it out. Okay, that's straightforward. Then you come to another eye movement abnormality like this. Again, intuitively, you can come up with various diagnoses, but foundationally, it's better for you to draw the diagram and realize that this patient's red arrow would be on the adducting eye, and that will be giving rise to a number of diagnoses, and you have to consider a number of diagnoses: restriction of one muscle, neuromuscular junction problem, third nerve problem, or a problem between the two nuclei, the so-called internuclear ophthalmoplegia. Here, after you have ruled out a localized restrictive problem, neuromuscular junction problem, cranial nerve third problem, then the presence of this abducting nystagmus in the other eye, which is due to overstimulation of the intact nerve, tells you that this is most likely due to medial longitudinal fasciculus lesion, due to internuclear ophthalmoplegia. Okay. So then we gave a more complex case, but again, you could break it up because again, you went step by step. One step is look to the right. Then the next step is look to the left. Okay. Then you put both of them together. Again, could be a muscle, neuromuscular junction, nerve, or because these two medial longitudinal fasciculars are so next to each other, it could be a bilateral INO. And the presence of the intact convergence, which is a different eye movement, because it convergence, unlike saccadic movement, requires visual stimulus and is coming directly into the third nerve, not through the medial longitudinal fasciculus. Medial longitudinal fasciculus lesion in the pons would spare convergence. So the sparing of the convergence in her confirms that it cannot be a localized muscle, cannot be neuromuscular junction, cannot be third nerve. It can only be a medial longitudinal fasciculus in the pons that is only catching the fibers coming in through the MLF without catching the convergent fibers. Okay. Then we talked about gaze. Okay, lateral gaze. And we realized that lateral gaze is controlled by the 6 nucleus. So the 6 nerve nucleus has got greater responsibilities than the nerve itself. It controls ipsilateral gaze. Okay. But not only does it control on its own reflexly, but volitional movements, the command is sent to the 6 nucleus by the cross frontal eye fields. And this is the part that you need to memorize. It is not ipsilateral frontal eye field, it's cross frontal eye field. So anybody who has got a difficulty looking to the left, therefore, could have a lesion in the 6 nucleus, lateral gaze center, or the frontal eye field. And to differentiate that, I give you 3 steps. Look for the side of hemiplegia of the limbs, look for the type of facial weakness. And finally, we use this to explain how to connect the 8th nerve to this network of fibers. And we realize that using the vestibular dance, by just turning your head left and right without using memory, you would be able to work out that you need to connect the contralateral 6 nucleus to the ipsilateral, or other way around, the ipsilateral 6 nucleus to the contralateral 8th nerve, because the movement, the turbulence is maximum in the contralateral 8th nerve vestibular system, then has the semicircular canals, and that has to be transmitted to the ipsilateral 6 nucleus to effect abduction of the eye, so that without even thinking about it, you can voluntarily foveate as your heads are turning left and right. That is the vestibular ocular reflex, or the Doll's response. So knowing that, you are able to use that as an additional tool to differentiate between a frontal eye field lesion where the vestibular ocular reflex is not affected, okay, and differentiate it from the 6 nucleus lesion where the vestibular ocular reflex will be affected.
Right.
Okay, and then to prove to you that the egg diagram is very useful even when it comes to a complex eye movement disorder, and the steps And the key point here is not actually the formula itself, but the understanding that everything in science you have to break it down in steps. So first step, egg diagram to the right, second diagram, egg diagram to the left. And then you put these two together. Of course, there are other ways of explaining, but the most parsimonious explanation, the most elegant or the simplest explanation would be a lesion, a small lesion affecting contiguous structures in the ipsilateral pons, causing movements, affecting movements, all horizontal eye movements except for contralateral abduction. So that's why it's known as a 1.5 syndrome. Okay, so that's the summary. Now, if it's okay, in the last 10 minutes or 20 minutes, I think we're supposed to finish at 3:30, but we should be able to finish earlier. We will slightly change gears to show that the same set of eye movements can be used, the same set of egg diagram can be used to explain nystagmus. Do you remember at the beginning, I told you the mission of this lecture is to tell you that eye movements and nystagmus, if you break it down into the mechanistic aspects of it, it's actually quite beautiful and not complicated. Okay, so we have told you eye movements are not complicated now with the egg diagram, but we also want to tell you that not only is it not complicated, but nystagmus is actually very beautiful. Okay, so let's think about a peripheral problem. Okay, let's say a person comes in now with acute lesion in the 8th nucleus. Okay, 8th nerve. Okay, a classic condition is vestibular neuronitis. Okay, sudden viral inflammation and damage to the 8th cranial nerve. So you put a thunderbolt across this 8th nerve. So what do you think is going to happen to this diagram? Okay, now if you just look at my face now, all of you look at my face now. So remember just now when I was talking to you, my head was turning continuously left and right, but I was still without any energy expended from my frontal eye field. I was still able to foveate on the camera without any effort because my vestibulo-ocular reflex is working. Okay, so when I turn my head to the left, this one had more turbulence. When I turn my head to the right, this one had more turbulence. And the increased turbulence is then transmitted to the contralateral 6th nucleus to effect this horizontal eye movements. So, but at rest position, both the semicircular canal have equal amount of basal, B-A-S-A-L, basal rate. Okay, they're firing at basal rate. When I turn my head to the left, this one has got more stimulus. When I turn my head to the right, this one has got more stimulus. Okay, at rest, both of them are firing equally. Now, what I'm doing is mischievously coming in and damaging this left semicircular canal system by cutting off the 8th cranial nerve or damaging it by viral inflammation. 8th nerve is completely gone. Poof, gone. Okay, 8th nerve is gone. Okay, so now remember, these guys were firing at basal rate. Suddenly, this one is gone to 0. This one is gone to 0. Okay, this one is still firing at basal rate. This one is gone to 0. Now, as far as I'm concerned, as far as my brain is concerned, this is equivalent to what? This is equivalent to this damage of the left 8th nerve here. Complete abolition of the signals from the left here. But this is firing at basal rate. It's equivalent to this firing more and this firing less, right? So what kind of stimulus does that? When my head turns my head to the right. When my head turns to the right, this one was firing more, remember? But now my head is not turning, but this guy is firing at basal rate. This guy has gone to 0. So as far as my brain is concerned, this is stimulus is equivalent to my head turning to the right. When my head turned to the right, what happened to my left eye? My left eye abducted, my right eye adducted. All right, my right eye, left eye abducted, my right eye adducted. Okay, so now even though my head is still there, because this guy is firing at basal rate, this eye is gone. My eyes are going to move as if my head turned to the right. When my head turned to the right, my left eye abducted, my right eye adducted. So therefore, even though my head is straight, still looking at the camera, my eyes are now going to drift slowly towards the left and the wall there. I'll be looking at the wall. Then I'll be thinking, oh my God, why am I looking at the wall? I'm supposed to look at the camera. So what do? I send a signal from my frontal eye fields, which are still working, send to the 6th nucleus and push it back to the camera because I want to look at the camera so I can continue talking to you guys. Correct? So I'll push my eye back voluntarily back, okay, or reflexly back to the camera. Now, the moment I finish doing that and I continue talking to you, what happens to this imbalance between the two? It's still there, right? This guy is still firing at basal rate, but relatively more than this one, which is firing at 0 rate. So now my eyes are still going to get the signal as if my head is turning to the left, to the right. So my eyes are going to move to the left again. And again, my head will turn to the left. Sorry, my eyes will turn to the left. Then I'll be wondering, hey, why am I looking at the camera? Why am I looking at the wall again? I should be looking at the camera. So I'll bring it back to the camera. Okay, but once I bring it back to the camera again the stimulus is still imbalanced. And the imbalance is going to push my eye towards my left. And I bring it back reflexly back to the camera. It's a constant struggle now. It's going to drift back to the left and I bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. This is going on. As long as the imbalance is there, this is going on. So slow phase, fast phase. Slow phase, fast phase. Slow phase, fast phase. What is this? Nystagmus. So this is the basis of peripheral nystagmus. Okay, so when people talk about peripheral nystagmus, they are implying that the nystagmus is due to pathology in the peripheral vestibular system. Okay, peripheral nervous system, specifically the peripheral vestibular system. So the semicircular canal or its nervous connections are damaged. So in this case, the vestibular component, the eighth nerve is damaged. So all signals from the left semicircular canals are lost. This one is still firing. So the eyes are going to behave as if the head is turning to the right. So it's going to drift to the left. And reflexly, I'm going to bring it back to the center. So I'm having a vestibular nystagmus. So this vestibular peripheral nystagmus has got a few key characteristics, okay, which you need to memorize, okay, in the past. But now, today onwards, you don't need to memorize because the vestibular diagram will teach you all the key characteristics of it. Number one, where is the fast component? It's beating away. Which is the disease here? The disease here is the left ear. And the fast component is beating away from the disease here. So by looking at the fast component, you know which is the disease here. So in this case, my head drifts to the left, my eyes drift to the left, and I bring it back to the center. To the left, bring it back to the center. So I'm bringing my eyes back to the center, away from the disease here. So the fast component is away from the pathology. Rule number one. Rule number two, because the imbalance is between the left ear and the right ear, no matter what I do with my eyes, whether I look to the left, look to the right, look up, look down, the direction of nystagmus will always be the same because the imbalance is always the left ear not doing his work, the right ear firing at basal rate. So this imbalance is the same. So the fast component beating the right will remain the same whether I look to the left, look to the right, look up. It will never change and start beating towards the opposite direction. The direction of nystagmus is always the same. That's rule number two. Rule number three. Remember we said there were three semicircular canals, right? One pointing up, one pointing sideways, one pointing back. The other side, there are also three. So if the vestibular component of the eighth nerve is completely damaged, all the signals from these three are gone. All three gone. So the other side is predominant now. It's basal, but it's now 100% more than the other side because it's gone to 0. So this guy is super dominant, and this guy is super dominant, this guy is super dominant. But this guy and this guy, if you look at it, the superior semicircular canal and the posterior semicircular canal, although it's about 270 degrees like that. One is going up, one is pointing back. Now, if you draw the vectors, there is some level of these two forces are actually opposed. The superior and posterior, because they are not direct. One is going this way, one is going this way. They are not 180 degrees. If they're 180 degrees, they will cancel each other out. But they are almost pointing against each other. So therefore, there's some level of cancellation of the vertical and the posterior downward component. But what is unopposed is the horizontal canal. The horizontal canal has got nobody opposing him. So he's the king. So you're not surprised that the component of the peripheral nystagmus is predominantly horizontal because of the three semicircular canals that are remaining, these two are almost diametrically opposite. So they kind of cancel each other out. The only one that's not cancelled is horizontal. So the nystagmus is predominantly horizontal. But it's not 100% horizontal because unfortunately this guy and this guy are not 180 degrees apart. The superior semicircular canal, there's no inferior semicircular canal, it's posterior. So the superior is here and the posterior is here. So they are about 270 degrees. So if you draw the vectors, there is still some component to it. And that's why if you look carefully, as you would see in subsequent video at the nystagmus, it's predominantly horizontal, but there is a little bit of a slight torsional component. So mostly horizontal, slightly torsional component. So three key features of horizontal nystagmus, you can work it out just by using the egg diagram. Number one, the fast component beating away from the ear. Number two, the direction of nystagmus can never change because the imbalance is always on one ear over the other. There's no business for the direction of nystagmus to change. Number three is predominantly horizontal, okay, with a little hint of torsion. Okay. Now if you don't believe this or not completely convinced about the explanation, let's work out the other way. Let's say my right semicircular canal is now completely damaged. My right semicircular canal is not working. My left semicircular canal is firing basal rate. So as far as my brain is concerned, my head is turning to the left. But my head is not turning to the left, it's still looking at the camera. But my eyes are going to behave as if my head turned to the left. My head turned to the left, my right eye abducted, my left eye abducted. So now if you hold that position, okay, my eyes, even when I'm looking straight at the camera, my eyes are going to deviate to the right. Right eye is abducting, left eye is abducting. But because I'm conscious, okay, there will be a reflex movement back to where I need to see it. So what I'm going to do, I'm going to bring it back to the center. But again, because the imbalance is there, okay, now this side is damaged, this side is firing, the eye should be pushed towards the right, and I bring it back, push towards the right, 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 bring it back. Now you see the fast component away from the damaged ear again. So by doing this vestibular diagram, you can work out firstly that what is peripheral nystagmus and the three main key components of the peripheral nystagmus. Only the fourth key feature of the peripheral nystagmus is not completely explained by this egg diagram, but is explained by something we explained earlier, the so-called Romberg's phenomenon. So in Romberg sign in the limbs, when a person has got peripheral neuropathy or peripheral problems outside the cerebellum, the patient is very, very unsteady. But the moment he walks into the rooms and says, "Doctor, I'm very unsteady," but then you notice he's still able to manage. But the moment he closes eyes, he'll fall. Then we call it Romberg's positive. It means that the pathology is outside the cerebellum. He's just able to cope using his vision to balance himself. Because if you use vision, you know the floor is always 180 degrees. Anything on the walls, the pillars should be 90 degrees to it. So I can use this to adjust my balance. Correct? So your eyes can use to do it. But once you close the eyes, you don't have that input. So therefore, even that cannot allow you to balance and fall. So in peripheral pathology, in the peripheral nervous system, in the spinal cord, the Romberg's is positive. But in cerebellar disease, which is the key orchestrator of all the inputs for balance, it doesn't really matter whether your eyes are open or closed because you're already going to be very unsteady. You're going to come in very unsteady because your cerebellum is not working. Whether you open the eyes or you close the eyes, the difference cannot be very dramatic because it is not the inputs that are faulty. It is the orchestrator of the balance himself is faulty. But if the orchestrator is working well, but your peripheral nerves are not working well, your dorsal column is not working well, then your orchestrator can then say, okay, let me take some information from the eyes. I'm using the eye information to balance myself. So that's what he's doing most of the time. But the moment you close the eyes, then you got no balance and he falls. That's Romberg's sign. So in other words, the cerebellum is able to cope with the visual input. So likewise, peripheral nystagmus like this is very disabling to the patient. Okay, you talk to the patient, you tell you, oh my God, I'm going to vomit all over you. I feel very dizzy. Okay, so what the cerebellum does is that it uses visual inputs coming through the fovea, coming through the retina, through the optic nerve, and uses that information to suppress the peripheral nystagmus. Cerebellum can do that. It can reinstitute balance. Okay. Now, again, if you take away visual input, then the cerebellum has got nothing to dampen this nystagmus. So the nystagmus becomes even more prominent. So I call this the Romberg sign of the eye. So Romberg sign of the eye is another sign to indicate that the pathology, the nystagmus, is indeed peripheral because the nystagmus becoming worse without visual input tells you that the cerebellum is coping with peripheral input from the eyes Therefore, the pathology must be in the peripheral nervous system because it's able to cope. But if it's a central pathology, which you will see later, whether the eyes open or not, just like in Romberg sign of the limbs, the patient will fall, the nystagmus will look the same. Okay. Now, without talking too much, I better show you an example. Okay. So this patient has got mild horizontal nystagmus that's peripheral in nature. And you can see a little bit of a rotatory component. It's beating to the right when he looks to the right. But even when he looks to the left, it still beats to the right. But it's not very prominent. Okay. But the moment I close his eyes, take away visual input, notice his nystagmus is much more prominent. Much more prominent than when we first started off with. Subtle nystagmus suppressed by the cerebellum because this is a peripheral nystagmus. So just like Romberg's, when you close the eye, patient falls. In this case, when you close the eyes, the nystagmus becomes even more prominent. This proves to you that this must be peripheral. So this is the last rule of peripheral nystagmus. Fast component away from the side of lesion. Nystagmus always in the same direction. Okay, a mix, predominantly horizontal nystagmus, and lastly, Romberg sign of the eye. So open his eyes, nystagmus dampens. Close the eyes, nystagmus gets worse. Okay. Now the next question you ask me is, how am I going to see nystagmus if the eyes are closed? So this patient's eyelids were very thin, so we could see it. For most patients, you try to close that, you can try, but most of the time you will not be able to discern it. So that's when some of you may have seen me carrying these glasses in my bag. So these are very thick magnifying glasses. Okay. Now, this thick magnifying glasses removes visual fixation from the patient. So if you put on these glasses, the patient will tell you, I can't see anything. But you can see the eyes very clearly, but the patient can't see anything because it's so thick and magnifying. Okay. So with the magnifying glasses on, you notice the patient's vision is removed, remember? So it's like closing the patient's eyes. Notice the nystagmus is very prominent. Now, the moment I remove the glasses, no more nystagmus. Nystagmus, no more nystagmus. Nystagmus, no more nystagmus. This is almost like magic, right? So likewise, the next, we only have one video of this patient. Huh? Do you have another one? I have one. I'll show you this one. Huh? This is another patient with very subtle nystagmus. Okay, nothing to write home about. But the moment you put on the glasses, the moment you remove visual fixation, the moment you do a Romberg sign, the nystagmus becomes obvious, proving to you that nystagmus must be from a vestibular pathology, not a central nervous system pathology. So nystagmus is present, but not very obvious. Now, if we take away visual fixation, much more obvious with the glasses on, right? So if you remove the glasses, then the nystagmus will disappear. So this is known as Romberg sign of the eye. Okay. Okay, so now we're going to put it on. Okay. So these are the key components. Peripheral nystagmus does not change direction. It's always in the same direction. Fast phase away from the side of pathology is mainly horizontal with a little hint of rotation, and it works with removal of visual fixation, so-called Romberg sign of the eye. Okay, so now that we have talked about peripheral nystagmus, we need to know what is central nystagmus. For central nystagmus, we need to bring in a few more characters to our plot, a few more characters to our drama, and then I have to introduce one more element for you to memorize. Remember, there are two things this whole lecture you need to memorize. Number one was frontal eye fields across. Number two, we'll tell you in a moment. Okay. So for frontal eye fields to work on the 6 nucleus, the problem with the frontal eye field is frontal eye field is just like the frontal lobe. It's not a very fascist, very definitive sort of creature. It's a bit of a hippie. It doesn't give very discrete commands. It tells you if you feel like moving to the left, maybe you want to move to the left. That kind of stimulus comes down. Now, that kind of stimulus is not enough for the 6th nerve to move to the left side. So it requires a much more deliberate signal. For the deliberate signal to come through, it has to pass through a transformer station. Okay, there's a group of neurons in the pons which takes the signal, takes the intent, because basically it's just an intent from the frontal eye field, takes the intent and then converts it into a more practical. Okay, if you like, this is a bit of a hippie, this is a bit more of a right-wing fascist. Okay, so he knows exactly what to do. This guy only says, okay, maybe if you feel like it, move to the left. This guy takes the command, okay, you want me to move to the left? Okay, now let me just execute this action. So he takes the command and converts it. Okay, now the technical aspects of it, you may have learned it in physiology. You don't have to. Okay, the technical aspects may be a little bit more complicated. You don't have to go to that level. So that this set of neurons, this PPRF has got this set of neurons called the burst neurons. Okay, which allows the signal, allows the signal, the intent to be converted into a burst of signal. Okay. But for practical purposes, especially for us clinicians who are practicing doctors rather than scientists who are more interested in the physiology of it, we can actually simplify the function of this group of neurons as go there neurons. Basically takes the content, the intent from the frontal eye field and converts it into a signal, go there. It takes a whip and says, go there, that kind of signal. Okay. So these go there neurons are it's discrete structures in various structures. For example, in the pons, there's a structure called PPRF. What PPRF stands for doesn't matter. Okay, doesn't really remember. You don't really need to memorize all these things. Just need to remember there are structures that convert these signals. Okay, and they are go there neurons. Okay, now then there is this signal is then sent to the 6th nucleus. But the go there neurons by themselves cannot function because go there neurons is just go there. It's almost like the first gear of your car. It allows you to accelerate, but it doesn't allow you to maintain the position. Okay, so you need a second set of neurons called the stay there neurons. Okay, so if you allow me to illustrate, my right frontal eye field now is sending a signal to ask me to look to the wall to the left. Okay, now I look to the left. You saw how I moved so fast, right? It was almost like simultaneously I was looking at you, the next moment I'm looking there. So it's many degrees, degrees in microseconds. So super fast velocity. For that to happen, your frontal eye fields cannot function on their own. The signal must be converted by this group of neurons called the go there neuron. So the go there neurons is the one saying, oh, so my eyes are able to start from 0 velocity, accelerate to a maximum. Can you imagine? Accelerate to the maximum. See how fast it is? So fast, right? So it accelerates to the maximum. But after it accelerates to maximum, it reaches the target. It cannot continue to accelerate there. Right? It needs a second set of neurons because accelerate, that means it'll be like you're revving the car at first gear all the time. You need to switch to second, third, and fourth gear to allow the car to maintain the position, maintain the speed, maintain the velocity. So the second set of neurons is called stay there neurons. Okay. The technical terms is neural integrator. Integrator because you can see from the formula here, it fires on an integrated manner. Okay. Integrated on the position and the speed of the eye movement. But we don't have to go into the details of it. Just remember that they're stay there neurons. Okay. Go there neurons and stay there neurons. So how does it work? My right frontal eye field sends a signal. Okay. Please try to look to the left. This signal is then converted by my left go there neurons. Okay, my right frontal eye field send to the left go there neurons will send a signal to my left 6th nucleus. Go there, my eyes hope. Okay, but once it reaches the target, my stay there neurons will kick in and keep the eye there. The second and third gear, keep the eye there. The stay there neurons, okay, are also discrete nuclei, okay, dispersed through the brainstem, but also prominently represented in the cerebellum. The stay there neurons. Okay, large parts of the brain's cerebellum has got stay there neuron function. In addition, there are multiple nuclei, okay, that are scattered through the brainstem, which have the stay there functions. Okay, now you can of course learn the names of these structures, okay, that are responsible for neural integration. But again, from a practical point of view, from a clinician point of view, you don't have to. But if you are really interested, you can go and learn them. Many of them have Latin names that sound like Harry Potter charms. Nucleus prepositus hypoglossa, for example. Okay, sounds almost like one of the Harry Potter charms, right? Yeah. So again, not important to remember the individual names because there are many structures like that, but important to remember generically they are known as theta neurons. Theta neurons are scattered in the brainstem and in the cerebellum. So now what I need you to memorize, just like I need to memorize the frontal eye fields across, not ipsilateral, cross, memorize that. I need you to memorize that for central nystagmus, the pathology lies in the theta neurons. Pathology lies in the theta neurons. So let's say now I've taken 20 tablets of phenytoin. Okay, and my cerebellum is completely toxified by phenytoin. Okay, completely screwed up. You know, phenytoin is a toxin to the high dose, toxic doses damages, not damages, but this causes disruption of your cerebellum, right? So let's say I took 20 tablets at one go, okay, and I became toxic from phenytoin, and my cerebellum is not working. So now my right frontal eye field says, look to the left. Sends the signal to my left Goda neuron. My Goda neurons in the brainstem are working well. Yes, they are working well. So I'm able to go there. Okay. But then my stay there neurons in my cerebellum are not working. So what's going to happen? Instead of staying there, it's going to drift back towards the center. But then now I'm very upset because now I'm trying to look at the wall. I don't want to look at you guys anymore. I want to look at the wall. I send a signal to through my frontal eye fields to my Goda neurons. And why am I looking at you? So I will send another barrage of signal. Frontal eye fields will tell a signal, please go look to the left. My Goda neurons will say, look to the left. Poop, it goes to the left. But my theta neurons are still not working. So it's going to drift back. Frontal eye fields send a signal to the Goda neuron, poop, goes back again. And then it drifts back, slow phase, comes back to the center. Then my frontal eye field sent through the Goda neurons, another barrage of signals, pop, it reaches the target, but it cannot stay there, it comes back again. So what is happening now? Fast phase, slow phase, fast phase, slow phase, fast phase, slow phase. Now I get completely disillusioned looking at the wall. So I decide to look at the wall on this side of the room. So I tell my left frontal eye field to send a signal to my right Goda neurons, to my right 6 nucleus to go there. So no problem, right? So I'm able to go there. But again, my cerebellum is not doing its job of staying there. So what's going to happen? After going there, it's going to drift. My left frontal eye field send another signal to the Goda neurons to push the eye there, and it drifts back. Now, left frontal eye field sends the Goda neurons. My eyes go there, but cannot stay there because my cerebellum is not working, it's drifting back. Now what has happened now? Now, fast phase, slow phase, fast phase, slow phase, fast phase, slow phase. Now, many of you would have realized there's something very remarkable. Just now, where was the fast phase? Towards the left. Now, where's the fast phase? Towards the right. And so, in other words, the fast phase, unlike our peripheral nystagmus, is not unidirectional. It beats to the left when I look to the left. It beats to the right when I beat to the right. When I look to the right. But if you don't believe me, I decide to look up. When I look up, no problem, because my Goda neurons are working perfectly, but my theta neurons are not working. So it's going to back to the center. My Goda neurons will push the eye back to the top. Theta neurons are not working, come back to the center again. So now the fast component is beating up. Why? Simply because I decide to look up. And when I decide to look down at my feet now, I look down at my feet, my Goda neurons are working, so I'm able to look to the feet. But because my theta neurons are not working, it's going to drift back to the center again. Pump, drift back to the center. 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 So now it's beating down. So what is remarkable is, unlike peripheral nystagmus, which is unidirectional, always beating in the same direction. Now, when I look to the left, it beats to the left. When I look to the right, it beats to the right. When I look up, it beats up. When I look down, it beats down. So what is the term for this? Gaze-dependent nystagmus. Okay, so a classic peripheral nystagmus is gaze-dependent nystagmus, and the terminology gaze-dependent nystagmus illustrates the pathophysiology. Because remember, the theta neurons are not working. So no matter where I look, I'm able to reach the target because theta neurons are not working. It's going to drift back to the center. So gaze-dependent. Now, a synonymous term for this nystagmus is gaze-evoked nystagmus. Now, both these terms are very useful. Therefore, we keep both these terms because it's gaze-dependent, because when I look to the left, beat to the right, left, look to the right, beat to the right, look up, beat up, look down, beat down, right? But it's also gaze-dependent because when I look straight at the camera, look straight at you, Nobody, you would never have guessed my cerebellum is screwed up by any time. No nystagmus at all, because I haven't evoked a gaze. Because only when you evoke a gaze, then the physiology, the pathology in the stata neurons is manifest. So this gaze evoked and gaze dependent nystagmus. Synonymous terms, both useful terms to use so that you can understand the interlocking implications these names give to the pathophysiology of central nystagmus. Okay, so let's look at an example. So this is what the diagram will look like. Massive disorders, whether it's in the one of the nuclei in the brainstem which are controlling stata functions, or a pathology in the cerebellum can cause this nystagmus. That's why you see central nystagmus very prominently in cerebellar disorders. Okay, like our patient that we saw last week at the tutorial, he had massive cerebellar disease, and that's why his nystagmus also was prominent. But we also thought that he could have a nystagmus in the brainstem, because in the brainstem, by chance, one of the neural integrators may have been damaged. If one of the neural integrators are damaged, then the Goda neurons may be working, but the stata neurons are not working, so you will get a central nystagmus. Okay, so this lady looks to the right, the nystagmus beats to the right. She changes her mind and looks to the left, and it beats to the left. Okay, but notice carefully here, when she was looking straight, nothing is happening. Only when you evoke a gaze. So it's gaze evoked nystagmus and gaze dependent nystagmus. So this lady had massive cerebellar disorders from the genetic cerebellar disease. So she has central nystagmus. So you realize that the two types of nystagmus that we talked about, and we use pathophysiology of the egg diagram to explain them. And they're actually beautiful because the mechanisms are quite straightforward. Okay, one of them is dependent on the imbalance in the inner ear function, the semicircular function. Another one is due to pathology in the stata neurons. Okay, two different pathologies. But why do we have to worry about nystagmus, whether it's peripheral or central? Just like Babinski's response. Why do we worry so much about Babinski response? Because when a Babinski response is present, we know the patient's weakness must be due to upper motor neuron disease. So similarly, when somebody comes to you with various complaints, like dizziness, okay, the presence of the type of nystagmus will tell you whether the patient has got a central vestibular disorder, a central disorder like a brainstem stroke, or a benign peripheral vestibular disorder like vestibular neuronitis. Both of them will come to you with dizziness, both of them will come to you with nystagmus. But by looking for the type of nystagmus, is it a unidirectional nystagmus that's beating away from the direction of nystagmus, that predominantly horizontal, that improves with opening eyes and disappears or worsens with closing of eyes, okay? Or is it a nystagmus that doesn't seem to make any difference whether you open or close the eyes, and that seems to be present only when you evoke a gaze, and it seems to change direction no matter where you look, keeps changing direction. It's so schizophrenic, left to the look to the left, beat to the left, looks to the beat to the right. Then central nystagmus will help you decide whether the patient in front of you has got a life-threatening stroke or a benign disorder like vestibular disorders. So that's why we use the nystagmus, although we revel in the beauty of the nystagmus because the pathophysiology is so beautiful to understand, but we use it practically like the Babinski's response to differentiate between central and peripheral disorders. Now, the next question is, are there other forms of central nystagmus? Well, the most important form of central nystagmus is the horizontal gaze evoked or horizontal gaze dependent nystagmus that we talked about. Okay, that's the 99% of the nystagmus of central nature that you will see will be this. Occasionally, you will see patients with upbeat or downbeat nystagmus. Okay, now the pathophysiology of the upbeat and downbeat nystagmus is equally beautiful, but it's a little bit more complicated and perhaps beyond the scope of what you need to know now. Okay, perhaps I would ask you now to just postpone that for maybe another later date or a later point in your career when you're much more seeing much more patients with similar disorders, because as a general doctor or a general internist or an internal medicine doctor, most of the time you would have to differentiate a peripheral nystagmus from a central nystagmus of the horizontal gaze evoked type. Okay. Now, occasionally when you will see a predominantly upbeat or a predominantly downbeat, just upbeat or downbeat at primary position, it is also central. Okay. Its mechanisms are beautiful to explain also, but just that, as I said before, it will take me another half an hour to explain. And perhaps we don't have to go to that level of detail because it's not common. Okay. So this patient, you can see at primary position, okay, at primary position, it's already beating down. Pum, 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 like a ping pong ball, it's beating down. So this is what we refer to as a primary position downbeat nystagmus. So when you see something like that, you know for sure this is a peripheral pathology. Another example would be this lady who's got a classic lesion in the craniocervical junction. You can see primary position downbeat. Okay, primary position downbeat nystagmus. Okay, this patient with cerebellar disease from cancer of the lung. Can you see? Pump, 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 pump. Fast component down all the time at primary position, downbeat nystagmus. Okay, so this all these patients that we talked about definitely central. Okay. Okay. Finally, what about upbeat nystagmus? Remember, vertical is upbeat, downbeat, all central. So this patient has got a brainstem midbrain lesion, and the lesion is causing a predominantly upbeat nystagmus at primary position. This patient has got a classic central nervous system pathology due to Wernicke's encephalopathy, important condition you need to know, because you can cure these patients with high doses of thiamine. And if you recognize it, so if you recognize his, you can see his beating nystagmus is pum, 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 beating up all the time. Okay, upbeat nystagmus. Okay, so the second part of the talk, we talked about two types of nystagmus: peripheral nystagmus, and we went through the key features. None of it need to be memorized as long as you can do the vestibular dance, okay, right in front of you, and that will tell you that it's due to an imbalance in the vestibular system. That's it. So this imbalance can only give you certain key features, and the four key features we talked about. Okay. Now, central nystagmus, on the other hand, is gaze dependent or gaze evoked, both are synonymous term, and the pathology is due to stay there neuron dysfunction. The stay there neuron dysfunction can be either in one of the nuclei scattered in the brainstem or in the cerebellum. Okay, and this is the part that you need to remember, that central nystagmus is due to stay there neurons. Vertical nystagmus, we didn't talk about the pathophysiology, but it's again something very central. But as I've said many times to my students before, if you one easy way to remember vertical nystagmus as central in nature is that, remember, if peripheral nystagmus is due to imbalance in the inner ear, what kind of imbalance in the inner ear can give rise to the symmetric up or downbeat nystagmus? Impossible. Okay, because remember, imbalance of one ear over the other gives rise to this nystagmus that we just talked about, fast component away from the component. You do the vestibular dance. Okay, it could. If you selectively went and cut off posterior semicircular canal here, posterior semicircular canal here, and only allowed the vertical semicircular canal to function on both sides, then perhaps a peripheral disease can cause vertical nystagmus. Likewise, if you cut off both the superior semicircular canals on both sides, the only thing that's working is the posterior semicircular canal on both sides, then maybe you can call it downbeat nystagmus. But for that to happen, you must have a very sinister surgeon who goes in and just cuts off these two semicircular canals on both sides. Nature doesn't do that. Okay, so therefore, vertical nystagmus cannot be due to a peripheral pathology because it's so difficult to selectively involve symmetrically only the superior semicircular canal or the posterior semicircular canal selectively. Okay, most of the time the pathology involves all semicircular canals of one side. So therefore, vertical nystagmus can never be peripheral, always central. Okay, and that's the summary for the last part. Okay, I hope I've convinced you that nystagmus is indeed, eye movements and nystagmus is indeed beautiful, and you don't need any memory work for it. Okay, I'm going to stop for a few minutes for questions. I went past time, so those of you who have to leave, please carry on. The remaining ones can ask questions. 3:40. I'll wait until 3:45.